So before we get into a discussion of systematic reviews and meta-analysis, I think it's very critical to lay down some definitions. So, and there's three main definitions or three main topics that people get confused. So narrative summary essentially describes the primary studies that are included, draw some conclusions based on weighting of the evidence by the authors. The process is not really explicit and it's heavily biased. Systematic review is a process of comprehensively locating and synthesizing the research directed at a specific question using a very organized, transparent, and replicable procedures. A systematic review can stand on its own, or it can have a meta-analysis, or it could have multiple meta-analysis included in it. Essentially, a meta-analysis is a method. It's a statistical method for combining the quantitative results from multiple studies to produce an overall effect. So, in the honor of David Letterman, I'm going to give you the top essential criteria to be included in a systematic review and meta-analysis. First, identify the central hypothesis or central question. So, most or all research studies should be based on the principles of hypothesis testing, but just as important is it clinically relevant. It's been discussed by the previous presenters. And when I read a paper, I try to keep these two acronyms in mind. The FINER, which stands for, is it feasible, is it interesting, is it novel, ethical, and relevant? And the PICO framework, which really helps define the exact question to be answered. So the population, intervention, comparison, and outcomes. It aids in developing the eligibility criteria for inclusion in the systematic reviews, and it really avoids trawling of the literature. Second, did the authors review or follow any strict guidelines? So there's guidelines that are based on expert consensus and empirical evidence, and they help ensure quality of reporting. The most common one you see reported in systematic reviews are the PRISMA guidelines. It's a 27-point checklist that helps provide guidance over the conduct and reporting of systematic reviews, and it should be included in any systematic review that gets submitted. In addition, what I look for is if the authors have made any attempt to see if what they're doing has already been published, or if they have registered their studies. And there's a website called Prospero, it's out of the UK, that is an international prospective registry of systematic reviews that have been published or are in progress. So it's, when I get a systematic review, I usually go to that, I type in the topic to see what has been published on that systematic review or is in progress. There's some other resources there that I'm not going to get into just for the sake of time. Multiple databases, multiple portals. What do I mean by that? So the authors need to be methodical in what they're doing. So searching a single database will only identify a third of all relevant articles. And the primary databases that are often included are Embase, Medline, Cochrane, and you see them there. But then there's also secondary databases. Trial registries, meeting abstracts, web searches. And only searching one server will only give you a subset of the data set. So for a really comprehensive review, you need to have multiple portals, multiple databases, combinations of search terms and synonyms, and often getting the help of a clinical librarian or an information specialist. Number 4, quality. So quality of a review is directly associated with the quality of the source data. So you can't turn lead into gold. So the criteria should be chosen a priori. Really stringent criteria will limit your data set. Non-specific criteria, you'll get non-homogeneous data. I put language bias here on its own because I think it often gets glossed over, but by not only authors, but by reviewers. Articles are commonly excluded because they're not in the English language, and there's an expense in translation. But as you can imagine, some relevant articles may get inadvertently excluded. And there's a lot of controversy about this, about the relevance of this, but I think, to me, when I'm reviewing it, that's one of the things I look for as well. There's other areas of bias and ways to assess for bias. And there's different scales like the Newcastle-Ottawa scale and multiple other types of scales. And usually it's represented in a tabular or graphical format where the authors list all the different biases and go through each article and check off which biases are met or not met. Data collection. did the authors set definitions to clearly define and are consistent across all studies? Did they define the exact characteristics? The years of inclusion is critical. Demographics, sample characteristics, and another important characteristic that I look for, did the authors set primary and secondary outcomes and define them well for their study? So we haven't even gotten to the data analysis yet. Data synthesis. So should the data be synthesized? Should a meta-analysis be carried out? That's the big question. Everyone can put the data together, but should it be put together? And a lot of that is dependent upon if the studies have similar outcome definition, size, characteristics, and interventions. And what they're doing is they're essentially combining the studies to get an essential overall effect size. Heterogeneity, that's a word that has been tossed around a lot, has been tossed around this morning. What does it mean? Heterogeneity is very important in systematic reviews. It's the extent of variation between study size effects, and there's different types of heterogeneity. There's statistical heterogeneity, clinical heterogeneity, and heterogeneity in methods. Most authors will account for heterogeneity through two different models, a fixed effects model and a random effects model. And what that essentially boils down to, a fixed effects model essentially means that there's minimal heterogeneity, there's minimal study variation, and confidence intervals are very tight. A random effects model means that there's significant heterogeneity, there's significant variation in between studies, and they have wider confidence intervals. There's different ways to assess for heterogeneity. There's a visual inspection of the forest plots, and I had a bunch of other slides in here that I've excluded that would show you how you would do that, but essentially just by looking at a slide at a forest plot, you can tell if there's significant heterogeneity or not. Really, it depends on how much of an overlap you have of the confidence intervals, and if all the point estimates are on one side of the line of no effect or on the other side of the line of no effect. There's a statistical way of doing it. There's a Cochrane Q test, which is really not as reliable, mainly because it's influenced by the number of studies in the meta-analysis. The I-squared statistic is more reliable. It's the percentage of variance in meta-analysis that's attributable to the study heterogeneity. It's independent of the included studies. Essentially, if your I-squared statistic is lower in percent, it means you have minimal heterogeneity. The higher the percentage, the higher the heterogeneity. So just a forest plot 101. The studies are typically listed in that first column. Number of events is very critical to pay attention to, because just because a study has minimal heterogeneity doesn't mean that if those studies should be combined where the overall effect is reliable or valid. The weights, this is assigned based on the degree of study precision. So the smaller the confidence intervals, the more precise the study, the higher the weight of the study. And then finally, these little boxes here, they're different sizes as you can see, and it's really dependent on the weighting of the individual studies. The overall effect measure, which is that one right there, is a weighted average and is inversely related to the study precision. For the studies that are more precise, they have more weight in the combined effect measure. And the line of no effect essentially means that there's no difference between the two treatment groups. Oftentimes at the bottom of the forest plot, you get this heterogeneity assessment. There's this first P is the Q, which I don't really pay much attention to. This is the I-squared statistic that I pay attention to, and that usually gives you an idea of the heterogeneity. So for example, in this one, there's minimal heterogeneity. Publication bias is very critical that the authors account for. Surgical literature is fraught with publication bias because as surgeons we like to publish positive results, no one likes to publish negative results. And it's ideally represented in a funnel plot. It's very important to have a funnel plot, but the funnel plot itself does not identify the cause of asymmetry. You could have a small number of included studies, and that would alone produce asymmetry. And there's methods to correct for bias as well, which I won't get into. So funnel plot basics. The y-axis is a measure of the study accuracy. The x-axis is the outcome measure for each study. The studies that are listed up top or at the top of this funnel are usually represent the larger, more precise studies. So you kind of want to see a nice funnel plot like this, meaning that it's symmetric, there's minimal bias, there's studies aligned on both sides of the overall outcome measure. Whereas this one is asymmetric, there's not a lot of studies that are aligning in this area. Sensitivity analysis is important that the authors account or do some form of a sensitivity analysis when I'm reviewing a paper. So essentially comparing two or more models to assess to see if the results are consistent under different assumptions. And what does that mean? So you repeat the primary analysis with an altered data set or statistical method. So for example, studies that were excluded for some reason, you would include, or you would alter the model. You would go from a fixed effects model to a random effects model. And it's really at the author's discretion, and the goal is essentially little change in the overall study outcome or estimate. And finally, did they do some form of a subgroup analysis, which was done in this paper, and essentially is estimating the effect size for certain groups that are a subset of a population of interest. It's very different than a sensitivity analysis, and really should be limited in number and planned in advance. And you really do risk a type 1 error. By increasing the number of analyses, you decrease your sample size and you may reach conclusions that really aren't there.